Thank you, Dr. Coletti. Okay, well, it's been a very informative and exciting morning, going over a lot of information on digital dentistry in general, and hopefully, you know, with our presentations that we're providing, we can spark some conversation and maybe some questions and just any concerns anyone has about any of the material that we've discussed so far, and we can review that before we all finish in the afternoon. So let's begin with guided surgery. So we've already discussed this morning about different cases that why we would do guided. What are the benefits of a guided surgery versus doing a free-handed surgery? And like Doug was saying earlier, some cases are, it does not make sense to do a guided surgery because of maybe this is a patient that walks into your office for the morning, they have an emergency, they broke a tooth, they're in a lot of pain, and they don't have time to wait for us to generate or print a surgical guide, and they want us to help them as soon as possible. So this is a case where this patient fractured his front tooth, and but he was not in pain, so thankfully we could do a guided surgery in this case. And so we evaluate the radiograph with just a periapical film. And we know that this is a root canal treated tooth, and medical history of high blood pressure and arthritis. This dental history has had a root canal. It was done a long time ago, and now is non-restorable due to the fracture. So we saw this earlier where we had the cone beam 3D X-ray imaging, and we merge it with the intraoral scan that we took of the patient, and we can plan the position of the implant. Based on this radiograph, we can determine where is the bone. Do we have room to place an immediate implant, or should we stage this case? Sometimes there's not enough bone to place an implant at the same time as the extraction of the tooth, and it just makes more sense to remove the tooth, place a bone grafting material. I like to use a allograft bone grafting material to help regenerate the site, and then sometimes you just have to graft and wait and cover the site with a collagen membrane. We've been using collagen membranes for the past 2 days in the clinic this week, and sometimes that's what you have to do to regenerate the bone, to establish a proper foundation to place a successful implant. So, you know, a lot of these things that we're showing today, like what Dr. Kim was showing earlier as well, and what Doug was showing earlier, was making, you know, dentistry more efficient and predictable and safe. And sometimes that means we can go with more efficiency on surgery, meaning we can go faster on the appointment, but we're not interested in fast dentistry, we're interested in safe dentistry. So in this case, we were able to place an implant with the bone that was remaining at the apex of that central incisor. And thanks to this technology, we can evaluate you know, possible implant size. We selected a 3.7 by 13 millimeter implant, and we know that based on research performed with Dr. Dennis Tarnow, he has discovered that there's a good rule of thumb to evaluate how deep do we place an implant. You know, in the aesthetic zone, in the anterior aesthetic zone, we've seen cases, and I've done many cases where I didn't understand the proper depth of how deep do you place the implant. How deep is deep enough, and how deep is not deep enough. So with the research that Dr. Tarnow has discovered, we can evaluate the mid-facial gingival margin of the adjacent teeth and measure 3 to 4 millimeters apical to that imaginary line that you draw. So if you were to draw a line imaginary, and let's say this is the gingival margin of this lateral, and you connect a dot from this position to that position, and this is the gingival margin of the adjacent teeth, and this is an otherwise healthy periodontal patient, meaning no horizontal bone loss, you can draw a line from this spot to this spot and measure 3 millimeters apical, and that is considered a safe position to place the platform or the top part of the implant. And without that information, this is all just a shot in the dark, and we don't really know how deep to place it unless we do some research and measurement and planning. And planning all this in advance makes the surgery day, which is really a very stressful and important day, makes this appointment go much smoother and more efficient and stress-free. It makes dentistry even more fun to do, because dentistry can be very stressful if you're lost and there's a lot of pressure, and this is a front tooth, right? Okay, so let's keep going. So this is how the scan looks before we've extracted the tooth. There's X marked here because this is our tooth that's planning to be extracted. Notice where that green cylinder is right there. So like Doug was showing earlier, he was showing that surgical kit that had what we call those paralleling pins. Paralleling pins are there for our prosthetic positioning. This is like we put a paralleling pin inside of the implant. So it's telling us where the straight line axis of the implant emerges from the prosthetic position of the tooth. And we have it right out of the lingual surface of that front tooth, the cingulate. This is an ideal position for a screw retained restoration. And so the day of surgery comes, we're using this. You might notice that we're showing this kind of clear plastic film that helps just retract the cheeks out of the way. I notice some of my patients have a lot of facial hair, so they have like a thick mustache right here, and sometimes that hair can block the view of what you're trying to work on, which is this front tooth, and sometimes honestly it's not very hygienic, and so this is what we call an obtrugate, which is a fantastic disposable piece of material that helps us see where we're working, keep the lips out of the way, and it sort of creates almost like a softer sort of bite block where they can have something to rest their jaw on and not have to strain their jaw muscles to stay open, because sometimes these are long procedures. So then I like to use this instrument here. This is really just a straight elevator. It's got a gold colored metal end here, but really the most important part that I love about this instrument is that it has a very thin edge or a thin curved beak at the tip. And so this becomes sort of a periotome where I'm using just light to moderate pressure to leverage the tooth out of the socket. Because you can see when that tooth starts to, if you were to luxate on this tooth, remember it's cracked. There's really no, what are we going to grab onto here? So if you try to take this tooth out, this whole top part of the tooth is going to just fall right off. And then trying to grab that root with a forceps, that's very difficult. And not to mention difficult, assuming you can even get a good grip on the tooth with the forceps, there's the risk of the buccal plate and the bone coming out with the tooth. So there's a lot of things we're trying to do. We're trying to preserve the bone, the hard tissue structure. We're trying to preserve the buccal bone right here. We're also trying to preserve the soft tissue. So with all these things put together, this is the technique that I've found very successful, and we're using this, what we call a luxator, which is that straight elevator, and I'm pushing on the mesiolingual and the mesiofacial line angles. Just moderate pressure. I'm not trying to push real heavy. Notice the tip of this instrument is very sharp. And so this is where control, focus control of your instrumentation is going to help you have a successful implant surgery. Because remember, patient safety is number one. We have to make sure we keep the patient safe. Do no harm. So we're gently elevating that tooth out. Once the tooth is removed, we have to evaluate where is the bone. Sometimes on the x-ray, we saw the 3D cone beam, it shows maybe there's no bone. Maybe it shows on that buccal plate in front of the root, there's no bone. But sometimes there's actually a thin amount of bone that's really there, but the tooth was more dense on the x-ray, and so the density and the artifact scatters of the x-rays can affect what we see on a cone beam. But we're checking the implant site to see where is the bone, and check the soft tissue, make sure all the roots out, and then we seat our surgical guide. So we seat the surgical guide, and we also have these little cutouts right here, and over here, and over here, and over here. These are windows created by the, well, they were designed in Real Guide, but the reason we have these little windows is so we can make sure that the guide is fully seated. Sometimes the guide may look like it's seated, but it may have something preventing it from seating all the way. We would never know if it was seating all the way unless we have these little cutout windows right here. So we should see the guide fully seated against the tooth and no empty spaces. And we place our implant. Again, this is a TSX implant. So we chose TSX. We could have also used a TSV implant, tapered screw vent implant. But like Doug was showing earlier, he showed a graph earlier that had primary stability measured comparing a TSX versus a TSV implant. And we know that with an immediate implant, we have to make sure primary stability is achieved in order to have successful surgery. And so when we really need to make sure we have successful primary stability, we're going with TSX. And we evaluate where is the implant placed. We can see the perioprobe here. We can see where the palatal bone level is. And the implant is placed apical. And so we're just checking the depth of how deep the implant's placed. Take our radiograph, our torque. We got to 40 newtons on this implant. And this was all achieved because we had a guided surgery. So this procedure could have easily taken maybe an hour, hour and a half, if we're really not sure about how to do the surgery. Because we would place the implant, check the angle, oh, maybe we're too facial, too buccal, take out the implant, drill again, check the angle, oh, we're not at the right angle, take out the implant, drill again, put the implant in, check the angle. Now the implant's kind of loose. All this back and forth. We take out the implant, put it back in, take it out, put it. So if we know, you guys ever hear the saying, measure twice, cut once. So plan, plan, plan makes for an accurate procedure. 4 months later, we're using a scan body here. I wish we were using an encode on this one. But this was before I was using encode healing abutments. And ever since we can use encode healing abutment, I only do it that way because it's so much more efficient. This is our scan. We have our scan body there. And we have to consider a lot of things when we're restoring this. You know, what kind of gum tissue is there? What is the gingival biotype? Does the patient brux? Are they grinding their teeth? And do we have a hygiene protocol established for this patient so that he can maintain the health of his implant? So we heard earlier from Dr. Kim that implants are wonderful. They have a lot of advantages. They don't get caries. They don't have decay. You can't get a cavity. and they're very strong, but they can fail. And so gum disease, periodontal disease, is one way that implants can fail. It can cause them to become less stable and have to be replaced. So good oral hygiene is a good fundamental philosophy that we have to establish with our patients, especially when they're getting implants. Some of these cases are repeats because we saw them earlier, but this was the case where multiple missing teeth, and we saw this planned already. So we're going to go through this a little bit quicker. But these types of cases go so much quicker whenever you've planned everything in the comfort of your office or on a computer, and you have time to study. You know, you look at the bone height, and you look at the room. You know, what are the teeth going to look like? Sometimes with these empty spaces, there's less space than what we really need to put the proper shape of the tooth there, and so sometimes we have to look at changing the shape of a tooth that we would like to place. Sometimes we don't have room to put a molar right there. We might only have room to put 1, 2, 3 premolars. Or we might only have room to put one normal size molar, and then we have to compromise or sacrifice on what the ideal shape of tooth could be. Or maybe we decide to not do any compromise at all, and we say, you know what, let's consider ortho. Let's consider Invisalign or braces to create more space before we do the implant surgery, because we've already planned where the teeth are going to go. Instead of placing implants first, and then getting to the restoration phase where the teeth are not looking good, they're there, the implants are good, but the teeth, the aesthetic failures, we talked about failures are also aesthetic failures is considered a failure. So planning properly for comprehensive care dentistry, digital guided surgery helps us do that. It's really an all-encompassing benefit for the patient. So we go through these kind of fast. So there are some advantages to doing a guided surgery. Oftentimes we're able to do what's called a flapless surgery. And I didn't put the citations here, but there are good evidence-based research that supports when a flapless surgery is indicated and when it's not indicated. Sometimes, like we saw Monday and Tuesday, there are some cases where a tooth has been missing for many years. The bone is adequate, but the soft tissue is deficient. And so in order to create an ideal soft tissue characterization for the implant, we need to do a flap surgery. So sometimes we do a lingual line incision, augment the soft tissue toward the buccal, place the implant at the proper position, and then we have an apically displaced flap. We move the keratinized tissue toward the buccal, and we suture it around the healing bone. And now we have keratinized tissue that's going to protect the final implant restoration. Those are cases where we want to do a flap. And in other cases where there's abundant soft tissue, maybe flapless technique makes sense, but it's very important to get comfortable reflecting a flap. Creating a flap is very, very important. And no matter how small or how big the flap is, they'll all heal, but you have to make sure that you're comfortable and that you make a plan on how to create the incision for your flap, and then how you're going to close the flap. Are we going to achieve primary stability? Are we going to use resorbable sutures? Are we going to use non-resorbable sutures? What's our material of choice, and plan in advance? This is the case we saw earlier, the external root resorption. So we'll go through this. So we already planned it. We removed the tooth. So same method here. I'm using the luxator right here, and we're just gently pushing around the tooth because there's very little tooth structure. So trying to remove this tooth without it cracking or breaking is very difficult unless you take your time. Don't be in a hurry. This isn't fast dentistry. Want to do it right. Remove the tooth. So I'm using a forcep here only because we already had mobility of the tooth. Tooth comes out in one piece. Sometimes they don't. Sometimes they break and you can't help that. But shaping the soft tissues, seeing the surgical guide, place the implant. Implants going in. We're using an Optrogate here. You can see that, just like we said earlier. There's our provisional. We saw this one earlier too. This is another case where a patient is 76 years old and his chief complaint is he just wants implants for his bottom teeth. He has implants on the upper, but now he wants implants for the bottom. And his medical history is a history of hypertension, kidney disease, joint replacement, and diabetes mellitus. He's taking some medications, metoprolol, Eliquis, aspirin, allergic to amoxicillin. Here's how he presents. His implants, they don't look ideal, but they're functioning for him. They're okay. There's no mobility. These implants are over 15 years old, and now he's tired of wearing his partial denture on the bottom. These teeth are very short, they're heavily restored, and they have recurrent decay. So he wants to do implants on the bottom. He wants the same type of restoration that he has for the top, where these are locator abutments, and he's wearing a denture, so they're going to be able to click into the implants. So they're still removable, but they have implant anchorage support. So this is a case where, because he still has some teeth there, this is a good case to do guided, because we're going to be able to use the information from his digital scan and overlay with the cone beam that he has, and you'll see these anchor pins right here. These are blue. You see those blue looking pins right here. These are actually going to be drilled into the bone to help stabilize that surgical guide. So this is an anchor pin fixation, and these are going to be removed right after we finish the surgery. We position 3 of them, and you can see all 3 of them there. And then we plan our implant placements. RealGuide also lets us put the planned locator abutment, which is that connector to the implant that's going to help click into the future implant locator abutments. So this one right here, because we know on a surgical guide, we know where this lingual concavity is right here. This is on his lower right molar. Without a cone beam and without a surgical guide, we would not know where that concavity is right there. And so we can avoid a complication here, because it would be easily possible to drill straight through this bone right there. If we drill through that bone, we increase our complications, have a perforation on the lingual side of the mandible, and potentially damage vital anatomy on the floor of the mouth. So because we have a surgical guide, this is a much, much safer procedure. So this one shows up red. So remember, we saw red earlier whenever it was pushing against soft tissue. We can see where the inferior alveolar nerve is here. And if you look around this implant, there's sort of a halo, this little green line going around the whole implant. And this green line is a safety zone. So a safety zone is important because it tells us when we're getting too close to something important, like the nerve of the jaw. And so it's showing up red because a couple things. One could be this implant is sunk deeper into the bone, subcrestal, by approximately 2 millimeters maybe on the lingual, and we're at the crestal level on the buccal, but we're also almost less than 2 millimeters away from the apex of the implant to the inferior alveolar nerve. That's why it's showing up red. So green, 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 red is bad. Something's going on. We just need to make sure we know what it is and if we're comfortable with it or if we need to change the angle. But one of the other things I like about this software is when you're placing multiple implants, sometimes if you're freehanding the surgery, they can be tilted, leaning, not all parallel. When you're doing them guided, you can make a very nice parallel path of insertion for your implants. So this is how he presents. This is the mandibular arch. You notice another thing here is he's got these lingual tori present, and we know that that is going to affect how the prosthetic sits on this bone here. But the bone is very wide, lots of keratinous tissue. There's the guide seated. So we have holes here, and right here in the middle too. These little cut-through windows help us to make sure that the guide is fully seated against the soft tissue. So we're drilling the fixation pinholes here. So this guide, this part is purely dependent on the guide sitting stable on the soft tissue. And a lot of times it's me holding the guide with my hand and my assistant with her hand, she's pushing on the other side. So we're both helping to keep the guide stable. These are the least accurate types of surgical guides you can have because it's totally soft tissue dependent. But we're turning this soft tissue guide into an anchor pin guide. So we can see white, the soft tissue is blanching. So we know that there's good pressure on top of the surgical guide against the soft tissue of the gum tissue. So at this point, now we can start using our tissue punch, tissue punch, tissue punch, tissue punch. Then I take this guide back off and I kind of scoop out where those tissue holes are, those circles are, and then I seat the guide back onto the mandible. And then I go through and we do our drilling sequence. So these anchor pins, you have to make sure they're pushed all the way down into the guide. Sometimes if you don't push hard enough, instead of the pin being flush right here, it's over here instead of it being right here. So you gotta make sure it's pushed all the way.
Rồi thì khi mà lắp cái anchor pin thì phải đảm bảo là cái anchor pin nó đi hết chiều dài nữa, nó cắm ngập vào trong cái màng.
So we're using our
nếu không thì có thể đôi khi là nó sẽ có những cái nó chưa được vào đúng vị trí, nó sẽ có những cái di động nhất định khiến cho cái màng nó không vững ổn.
This appointment goes so much quicker because all of the planning has been done, all the measurements have been done, the placement has been planned, and we just start going into each position. This is using the Z3D kit that Doug showed earlier, and it comes with this tissue punch that fits perfectly inside of each one of these holes. It's a snug, firm fit inside of the metal sleeves, and so it's very, 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 very precise. Use an explorer to try to see if that soft tissue is loose. Ideally, I would love to keep this guide on there. I don't want to take it off, but sometimes that soft tissue, because the ridge is not a tabletop flat, it has a kind of an arc taper to it. And so even though the tissue punch is going straight down into the surgical guide, the tissue punch is flat, but the ridge has kind of a dome shape to the top part of it. So sometimes there's still some periosseal membrane stuck to the mucosa, and you have to take the guide off to clean it out. So we did all that, we went through all the drilling sequence, now we're placing our first implant. So when these implants get placed through the guide, I place the implants through the guide. You don't have to do it this way. You could just drill through the guide and then take off the guide and then place the implants without the guide there. But to me, why would I do that? I might as well just use the guide to place the implants through it. It's even more accurate. We're getting a lot of stability here. So notice I'm stabilizing the head of that torque wrench with my other hand. So I'm right-handed. How many of you guys are right-handed? A lot of us, right? Sorry, lefties. We still love you. But a lot of us are right-handed. So I use my left hand to stabilize the top part of that torque wrench, and that helps me protect from having anything come off of that instrument, or possibly the patient swallowing it. Placing another implant here. So the stability is so good that sometimes there's so much torque I drill to hard bone protocol. I have to take the implant out and drill more, so that way this implant can go all the way in, because I'm getting at least 60 newtons of torque on each implant. Very, very, very strong. That's how aggressive the TSX implant is with this type of procedure, especially guided. Guided and TSX implants, you're going to get a ton of primary stability. There's a lot of success with this. And see, it's on so tight, you have to carefully kind of move the torque wrench around to get it off of the fixture mount. So I start in the front, work my way toward the back, and each time these implants go in and they seat all the way down on the surgical guide, they kind of act like an anchor pin. They hold the surgical guide in. So we also make sure that this top part, notice the hexagon shape of this fixture mount is matching the metal sleeves of the surgical guide. So for this case, because we're doing a locator implant overdenture, this is really less critical that they match. But if you were planning to place maybe like angled multi-unit abutments, like what Dr. Kim was showing earlier, these matching hexagons are what we call timing. So when a surgical guide has these metal sleeves in them, they're designed to have this hexagon in the angle and the orientation that you plan it in. So this is really kind of like a finesse. This is really more advanced, but we don't need this for this case, but it's just because I like everything to be nice and neat.
Tôi vẫn làm vì tôi quen cái quy trình này rồi.
Here we go. So then we get all four. So even though we did this procedure flapless, we're about to do a flap. We do a flap because there is so much bone, and he has such a tall ridge that we have to do an alveoloplasty to reduce the height of the ridge, because we're thinking about the prosthetics. We're thinking about how much thickness of denture material do we need to prevent a functional fracture of the denture. So I would at least like to have 12 millimeters of restorative space for this implant locator overdenture in order to have bulk strength for the material, structural integrity of the denture. Sometimes if the denture is too thin and they're chewing on something with their new implants and they feel great about it, the denture will crack and break, and they'll be upset because now they gotta pay for another one or come in to get a new one made. And sometimes you don't know until you know. So this is planning for the future. These little white caps here, these are the attachment carriers for these locator abutments. So even though we reduced so much bone, the panoramic looks like we didn't really take anything down, but he's got these lingual tori here, so on the panoramic it looks like it's real tall, but we saw on that that photo here, everything looks nice and flat right here, over here, and over here. He's got those lingual tori there, so that was a fun locator case. This is one for anterior front tooth. So 44-year-old Hispanic male, no medical history, no allergies, his front crown came off. So another endo, failed endo. And if you look real closely on the PA, the periapical film here, you can see the previous root canal treatment, and there's an empty post space. So must have had a post and core buildup that fell out. It has an old PFM crown, maybe some residual cement here. And this is preoperative. Preoperative, that tooth is a lot wider than the neighboring front tooth. So we know that there are some pre-existing spacing issues here. But his main concern, he's not concerned about how that tooth's wider than the other one. His main concern is this tooth is loose, and he wants it fixed. He wants to replace it. So we have findings and diagnosis, and our treatment plan. So we go through some options. What's another option here? Besides pulling it and doing an implant, you could also do a 3-unit bridge, right? So you could do maybe a lateral to central 3-unit fixed partial denture bridge right here. Another option could be to put a flipper. And I know that Dr. Schlissel hates flippers. With a passion, he hates those removable partial denture flippers, single tooth flipper. And he's 44, so he wants something more permanent and higher quality, so we're going to give him. This is what it looks like when you take the crown off. Recurrent decay, this is the lingual view. This is the facial view. And there's just nothing left to restore. So even if someone said, well, you know, I could save that tooth, I could do some Baroque dentistry and build it up and put a new post. He's 44. What's the most predictable option for him? We don't want him to have a Band-Aid fix and temporary fix continually for the rest of his life, and it's his front tooth, so we're going to talk about doing an implant. So same protocol, using Real Guide, 3D cone beam merged with the intraoral scan, and thankfully, he's got a short root, and look at how much bone is apical from the tooth socket to the nasal floor, and it's a thin runway. You know, I call it a runway. It's a thin thickness of bone right here between the buccal and the palatal. If you look real closely, you can see a green line, a green halo around the implant. This is our safety zone. So we have to maintain a 2mm space for ideal bone vitality. So that's what we want to maintain here, is we want to have a large enough implant that will give us the primary stability and the emergence profile that we want for his tooth. But we also want to have enough bone surrounding the implant to maintain bone vitality. Because bone, even though it's very hard, it is a living, breathing tissue, and it has to have blood supply. So if you put a larger implant in this area, you'll reduce the amount of bone thickness on the buccal and the lingual, and that will be less room for blood supply to go to those bone cells, and then you'll see more bone loss and complications. So we're also thinking about where and how deep to place the implant. We're measuring the distance between the imaginary line of the mid-facial gingival margin of number 7, or the lateral central, to the contralateral central. And we measured 3 to 4 millimeters apical. This is a long implant. This is a 16mm TSX implant. So we design the guide, we extract the tooth, same protocol, seat the guide, measure, and make sure that the cutout windows here are fully seated with the teeth. We know that the guide is fully seated, and we place our implant. 70 newtons of torque, 70. This procedure took maybe 20 minutes from start to finish, the surgical part. Now we still have to design a provisional implant restoration. We want to do soft tissue shaping. So we place our implant. We also put particulate bone graft on to graft the bone to implant gap here. There's no incisions. There's no crestal, sulcular, vertical releasing incisions because we didn't need to. Now, if we needed to, we should be comfortable doing that. We should know if we needed to. Maybe let's say this tooth had a infection and there was a bony defect on the apex of the tooth. And so maybe there is fistula or abscess formation here. We should be comfortable reflecting a flap to where we can gain good visible access to that defect so we can clean and remove that soft tissue that's infected and then repair that bone. But thankfully we were able to avoid that flap procedure. And we attach a healing abutment, or this is really a provisional, I'm using this as a provisional abutment, but it's really an angled tie base, which is, it allows greater flexibility for the screw access channel of the restoration. So there's a little cutout right here, so if we needed to, we could tilt the screw access channel more toward the lingual and hide the visibility of that screw.
Chúng ta vẫn có một cái vị trí cái lỗ vít nó thuận lợi dù là cái trục nếu mà đúng cái trục implant.
So the tooth is wider here, but because that space was so wide, he was not as concerned about that, more of just having the tooth right there. Not the prettiest, but he's a happy camper. So occlusion is also important here too, because I don't want patients to function on that front tooth. So even though I reduce the lingual occlusal contact here, when he's biting eccentric, he's going to eventually forget that he has an implant there and accidentally bite on his front implant tooth. So to some extent, there's really not much I can do. I can't guarantee. I can't prevent occlusal forces hitting this provisional crown, but I can do the best that I can whenever he's biting down with no food, that there's no contact here, and then also reminding the patient that this is not for chewing, this is just for looks, because any excessive forces on that provisional tooth will increase the chances that the implant could fail. But what's another topic that we've already been talking about today is primary stability. With the TSX implant, we had 70 newtons of torque. 70 Newton centimeters of torque means a very, very strong implant has a low risk of failure due to occlusal overload. Okay? All right, that's all the time we got. Thank you very much.